we are delighted to have Dr. Alan Bale as today's speaker. I don't think I needed any further introduction for Dr. Bale. He's a professor in our department and the director for the DNA diagnostic lab. If you don't know that Dr. Bale, you should order more testing to send to his lab, and then he will see the name on it. So, Dr. Bale, I'll take it over.
Okay, thanks. So this talk has three parts, basically. It has the part that's about sort of basics of radiation biology and how we get exposed to radiation. Then it has a major part that's about genetic syndromes that involve deficient double-strand break repair. And then a little bit at the end about a case that you'll see and about recommendations for how to handle people who have these syndromes. So the learning objectives are distinguishing dose ranges and potential toxic effects of different kinds of radiation we're exposed to, and then review genetic syndromes that predispose to radiation sensitivity and formulate rational guidelines, pretty much the outline I just gave you. I'm going to start out with a case presentation, as we often do in these talks, just to give you something to think about as we kind of go through this. But this is a patient that we saw in the Cancer Genetics and Prevention Program who was sent to us because she had T-cell ALL, but also some other features that suggested a genetic syndrome. She had a prenatal history of intrauterine growth retardation and a couple of funny malformations. When we saw her, she had always been small. When we saw her, she had a final height of 5 feet. She had delayed onset of puberty. She had an immunodeficiency that was being treated with IVIG, and she had a mild, moderate developmental delay, completed high school with special education. She wasn't really too bad, but she's living at home and she's not working right now. The mother was told by one of the patient's physicians that she might have a chromosome breakage syndrome, but no genetic testing was ever done. The family history is actually somewhat relevant in this case. There's no apparent consanguinity, but this ancestry is actually sort of important diagnostically. The physical findings when we saw her were that she was quite short, but she had a remarkably small head, 50th centile for a 2-year-old in an adult. She had a few kind of minor facial abnormalities. She had some minor dysmorphology. She was just had kind of an unusual face, but not a lot of specific stuff other than what I've written here. And she also had a somewhat ataxic gait. It wasn't very notable. She was perfectly able to get around, but she had trouble with things like walking in a straight line heel to toe. So that's the patient. Oh, geez, it's kind of presenting funny. Sorry. So I hope it's not going to keep doing that. But the patient's. So what's the patient's diagnosis? I don't expect you to know what it is. Maybe somebody does. But the question to think about right off the bat is what diagnostic test you should do. And later on, at the end of this talk, we'll talk about recommendations for her problems, the treatment of ALL, and whatever else she needs. So now I'm going to transition to the part of this talk that what I call the basics about radiation exposure. And it's pretty basic, but this is actually, well, I'll get to it. There's one slide here that is a major takeaway point of this talk. So this is kind of the boring stuff, units of measure, but I'm going to mention them because I use these terms. So it seems like these days people have kind of gone over to using grays and sieverts for measures of radiation dose. And grays are simply the absorbed dose of radiation. Sieverts are complicated because they're a combination of the absorbed dose and the effect of that dose. But for the purpose of this talk, it's real simple because a sievert is a gray if you're talking about X-rays and gamma rays. So those are the terms. I mean, I may go kind of back and forth between grays and sieverts, but for X-rays and gamma rays, the measurement is the same. This is a somewhat surprising slide, but I think that it's a good sort of basis for understanding radiation and our exposure to it. So the average radiation dose is 6.2 millisieverts per year. And on average, now this was kind of a surprise to me, but on average, half of that comes from man-made radiation. That is not true of the average person. This is an average of all people. So some people, as we go through this, you'll see some people get a bunch of diagnostic X-rays, and some people don't. Most people don't get a whole lot of diagnostic X-rays. But you know, if you have radiation therapy or you have lots of things like CT scans, it really increases the average, you know, the population-wide average. But what you should think about is that most people who aren't getting any kind of X-rays are probably getting half of this dose. That's what the background, sort of average background is in the United States. This doesn't have much meaning on this slide, but this is the big slide. If you don't remember anything else about this talk, this is the slide that everyone should remember. So this is a linear graph of radiation dose, and these points are just different, you know, types of exposure. But this is a linear graph, and the takeaway from this graph is therapeutic radiation is one kind of animal, and medical diagnostic radiation is a different kind of animal, and it's the same kind of animal as background radiation. People just cannot get this through their heads, but this is like being exposed to an atomic bomb or a you know, nuclear reactor meltdown. That's what therapeutic radiation is like. It's way up there. You know, diagnostic radiation is like background radiation. To sort of expand what this actually looks like, this is a semi-log graph of exactly the same information on a semi-log plot. So once again, you know, therapeutic radiation is way up there. What I would like to also demonstrate is that all medical diagnostics are either way below or fall into the same range as a year of background radiation. So if you have one CT scan in a year, that basically gives you the same exposure as a year of background radiation. Note that there is no type of diagnostic study that is significantly greater than the background radiation. This varies by like a factor of almost 100, you know, 30 at least, but probably more like 100. And so different parts of the world have very, very different background radiation. The U.S. is on the low side of this. This dot is probably 3.2 millisieverts. This place, Ramsar, Iran, has a tremendous amount of background radiation because they have hot springs into which radon gas is bubbling. And there is, I have read multiple studies of this area, and there is no increase in death from cancer in that area. Not that's measurable anyway. So that's like the range of background radiation in the world. And this is kind of an important point because of something I'll bring up later. I mean, it seems unimaginable to me that someone who's getting 100 times as much radiation as we usually are doesn't have a higher risk of cancer, but it's not a measurable risk in the studies that were done. The party line on health effects of radiation, I'm just telling you who the party line is. So everyone probably kind of understands this concept. If you have therapeutic X-rays, therapeutic radiation, it's this range, 1 to 2 gray per dose. And it causes all of these things that we know radiation therapy causes. The total dose from radiation therapy is usually 50 gray, but separated into these very small doses. If you got 50 gray all at once, you would be dead. You would die in days. That's down here. So that's why it's fractionated. So people who get that level of radiation do get bone marrow syndrome. If you get 10 grays all at once, it could be deadly. Oh, the other thing I should mention about grays and sieverts is therapeutic radiation is focused. It's targeted. And because it's targeted, you know, it's not like whole body. It's not like a whole body dose of 50 gray. It's a dose of 50 gray to some part of your body. You know, your body's getting a lot of radiation exposure, but it's not exactly the same as this. But anyway, everybody knows about these things. Like if there's a nuclear reactor meltdown right next to you, you're going to get these exposures and you may die. Everybody also probably knows that there's cancer associated with high dose radiation, which is this dose is higher than any background dose in the world. It's like, you know, it's 100 times what we're probably getting in a year. And that everybody knows this stuff, I think. It causes leukemias and multiple myeloma, also lymphoma not shown there. And, well, maybe lymphoma is kind of a solid tumor, but anyway, it should be here. Thyroid is a little complicated because a lot of thyroid cancer related to radiation exposure is from it getting into your body and into your thyroid. It's not from external exposure, but anyway, that's the idea. So that stuff's all background stuff that everyone probably kind of already knows. This thing is locking up. Hold on a second. I just have to go to this. All right. Low-level exposure is also an interesting thing. Again, this is the party line. No increased risk of death from cancer in people living in places where there are nuclear reactors. Basically, there's no genetic effect from radiation, and which might seem a little bit controversial or not obvious, but the thing is that the difference between getting mutations in your germline and becoming infertile is a very, very fine line in humans. In mice, not so much. You can mutate mice with radiation, but it's pretty hard to mutate humans with radiation. They just become infertile. This is the party line. There are no data to establish a firm link between cancer and low-dose radiation. But that's not necessarily true because there are a few analyses that say young people exposed to ranges that are in the diagnostic range, like multiple CT scans, have an increased risk of brain tumors and leukemia. And also, this is almost hard to believe, but meta-analyses show a very small excess risk of cancer in adults exposed to low-dose radiation. The reason this is hard to believe is this is like 10 times less than the background radiation dose in that place in Iran where there isn't a measurable increase in cancer deaths. So don't ask me. All I can say is the numbers are, the increased risk is tiny from low-dose radiation. There we go. Okay. So the next part of this talk is now talking about radiation repair syndromes. A few words about what does radiation do and what are radiomimetic chemicals. So radiation mostly causes, ionizing radiation like X-ray and gamma, mostly cause double-strand breaks, and to the extent that they cause other kinds of damage, it's just not as bad for your cells. This is what causes cells to die and to get mutated, for the most part. And cross-linking agents, also called bifunctional alkylating agents, secondarily cause double-strand breaks in DNA because the way that they get handled is this mechanism here where you end up with a double-strand break. So that's one kind of radiomimetic. There are probably other ones that I don't know about, but basically that's what we're talking about. So there are drugs that cause double-strand breaks, but mostly what we're talking about is ionizing radiation. The whole point of this diagram here is to illustrate that repair of double-strand breaks is a complex process. There's this kind of repair that's non-homologous end joining. It doesn't give you back what was there before the double-strand break. It causes mutations. And there's homologous recombination, which is high-fidelity repair. So this gives you back what was there before. You know, let's say you cause a double-strand break, but then you just can fix it through homologous recombination. I've just listed along here not every single player in these diagrams, but a bunch of them. And so this is all the players in these diagrams, if you mutate them, are causing some kind of DNA repair syndrome, many of which you've heard of, like ataxia telangiectasia, Fanconi anemia. These are all different Fanconi genes. So that's the background. And this is just another diagram that's kind of showing you the same thing. People with Fanconi anemia are particularly sensitive to cross-linking agents because that's exactly what they don't repair right. But other people, these people are also sensitive to cross-linking agents because, as I showed before, they cause double-strand breaks. And so these are like the cast of most of the DNA repair syndromes you've heard of. These are autosomal recessive rare conditions. There's one Fanconi anemia that's X-linked recessive. And that's sort of the general flavor of DNA repair diseases. And so this is another slide that I think is a good sort of takeaway slide, that you know, from a clinical point of view, these diseases are rare. That is, the real disease that's recessive is a rare condition. Patients are very sensitive to ionizing radiation or radiomimetic chemicals. I'm not talking about xeroderma pigmentosum in this talk. That's also a very rare condition, and they're sensitive to UVB. They also get internal malignancies because same kinds of things that UVB does just happen by chance and when your DNA is replicated, or just other chemicals in your body or whatever it is, but they get brain tumors as well as skin cancer. But I'm focusing in this talk about ionizing radiation and the syndromes that don't like it. A lot of these disorders have chromosome fragility, especially if you stress the cells. So you can see this when you do a karyotype. A lot of them have immunodeficiency. It's almost universal in DNA repair defects. A lot of them have developmental delay. That's not 100%, but it's frequent, and other neurologic findings are also frequent. Failure to thrive, predisposition, especially to lymphoma and leukemia, but some of these syndromes also predispose you to solid tumors, like weirdly. This is something I just learned through an unfortunate case I have to deal with, but you know, newborn screening now tests for SCID, for severe combined immunodeficiency, and unfortunately it also tests for ataxia telangiectasia and probably other members of this group of diseases. I don't know if Michelle's at this talk, but I mean, anyone who knows about newborn screening may not know this. I didn't know it, but unfortunately it is true. So when you get a positive test, it's not necessarily SCID. It could be something worse. These are just some specific features of more common syndromes. I think everyone's probably heard of ataxia telangiectasia. The key features of this one are, oh, I see something in the chat. Oh, Michelle's here. Yeah, good. Thanks, Michelle. So, Michelle, if you can speak up, did you know that DNA repair diseases are picked up by that SCID test?
You know, honestly, Alan, we never took care of those. The AI people always did, and we never got called. What I can tell you, when I used to talk to Jason, I talked to Jason Catanzaro about this a couple times when we were doing the various grants, and he said actually the number of positives period on this test has been exceptionally low. So I did not know that at all because we hadn't taken care of it, and there's weren't that many positives periods. So that's fascinating that happens. Yeah,
that's who sent me one of these cases recently. Oh, it's just dreadful. But anyway, so ataxia telangiectasia, they have pretty bad ataxia. I mean, they can become wheelchair bound in childhood, and they have telangiectasias of the skin. And little known, but medically important, is they also have telangiectasias of internal organs, and they can bleed, so they get like hematuria and serious internal bleeding. Nijmegen breakage, they have what they call progressive microcephaly because their heads just stop growing, and so their head circumference keeps getting lower and lower on the centile ratings, and premature ovarian failure in females and infertility in males are also kind of common among these syndromes, but not everybody. Fanconi is special because it has bone marrow failure. That's a lot of how these get picked up. But they also have malformations, like they can have absent thumbs, absent, sort of abnormal radial ray side, the radial side of your arm. And they get solid tumors, a lot of solid tumors, as well as leukemia. Bloom syndrome is notable because they're extraordinarily short. They're very, very short. It's called an extreme short stature syndrome. They have this sort of butterfly-like rash on their face, and they have a lot of problems. They just have cancers of many organs, infertility, just lots of health issues in Bloom syndrome. Rothman-Thompson is a little bit outside of the rest of these. They have skeletal dysplasia, and the kind of cancer they get is osteosarcoma, so they're a little bit different. And Werner syndrome, premature aging, it's not like progeria because it's actually a DNA repair defect, which progeria is not. But they basically get everything you get with premature aging. They're not so cancer prone though, which is like just a funny thing. So what about heterozygotes? Everything I've been talking to up till now was those rare recessive conditions. So what about heterozygotes? So here's like the revelation about heterozygotes. Basically, every Fanconi gene, practically all of them, if you look at them, are associated with autosomal dominant cancer predisposition. That's not 100% of them. There are some. I haven't even counted the number of them. There's got to be over 20 kinds of Fanconi anemia now, and they're not all associated with dominant diseases. But like the prominent ones are BRCA2 is FANCD1, same gene, exactly the same. BRCA1, BRCA1 like sort of flew under the radar for me that this was FANC-S. For years, we knew that there were very few people who were homozygous for BRCA1, and they were sick as heck. But I didn't realize, recently it's been classified as FANC-S because it's a Fanconi anemia syndrome. And this one, pancreatic cancer and breast cancer, maybe ovarian now, and a bunch of the other ones, they just predispose you to a bunch of things. And ATM is important because ATM heterozygotes make up something like 1 in 100 of people in the general population, and females with it have like a twofold risk of breast cancer, which is an actionable risk. So that's like, so they're also quite significant. This part is about what happens when you expose people with the recessive repair syndromes to mostly that's what I'm talking about, is what happens when you expose people with these autosomal recessive conditions to various kinds of radiation. So a lot of the information on this is either in vitro studies or it's anecdotal, because you can imagine these syndromes are rare and people just aren't getting radiated that much, but unfortunately sometimes these people are. The data on heterozygotes is kind of a little vague, and I'll show you what there is. And there are limited case series, and a lot of this stuff is for rare diseases. There's like nothing published. People kind of know because of anecdotes, but there's almost nothing published. But this is an interesting compilation of cases that's going to give you the complete deal about treating these people with radiation. So basically, don't treat these people with therapeutic radiation, or at least not in normal doses. So this was compiled by these guys. I don't know Pollard, but Gaddy has forever been studying ataxia telangiectasia, and he probably knows everybody in the country who has it. But anyway, you treat, these people do terrible with radiation. Most of them die, and I don't know why this person had no severe adverse effects. I can't explain that. These people, Nijmegen breakage syndrome, they die. Fanconi anemia, most of them die. These syndromes are so rare that you almost never, there are almost no reports of them, but they die or have severe toxicity. And that's what happens when you treat these syndromes with therapeutic radiation. They die. Note these doses, 3 to 30 gray, like these are therapeutic radiation doses. These are 1,000 times at least any kind of dose you would get with diagnostic radiation. This was kind of a revelation to me because I didn't know this. Radiation and cancer and these recessive diseases. I'm kind of just pulling information out of a few papers that are representative papers, but this was the risk of post-transplant solid tumors if you irradiate people for bone marrow transplant. So Fanconi patients do undergo bone marrow transplant, and they use low doses of radiation. I guess they use the minimum doses to do it, but these two groups were given the same dose of radiation to ablate their bone marrow. And among the non-Fanconi patients who had other reasons to have a transplant, they had a very significant increased risk of cancer. The follow-up here was like out to 15 years, so it's not forever, but it was long. And these people have no significant increased risk of cancer. You might wonder why that is true, because they're so sensitive to radiation, the killing effects of radiation. But I think that's where the answer is, because their cells die. They just don't mutate. They actually, I don't know, it's a little hard to explain, but I think what happens is the cells that would have become cancer just die. That's my interpretation. There might be a better answer that I don't know. And likewise, this is also true. No secondary malignancies after ablative bone marrow therapy for all of these other syndromes. And so they are not sensitive to the cancer-causing effects of therapeutic radiation and sort of radiomimetic chemicals, which is a little paradoxical. I would have thought they were, but they're not. So this is kind of, again, more or less what I would call the party line on what to do with these patients as far as radiation therapy and just radiation in general. So to make a long story short, basically, most of these syndromes that we know about, there are recommendations to not use therapeutic radiation or use tiny amounts of it if you have to use it. And a lot of this stuff, like, there's just no clinical data. So that's something of a problem. Werner syndrome, they just don't seem to get the same excess toxicity that other people get. So the take home is there's a wide acceptance of avoidance of therapeutic radiation or radiomimetic chemicals. Avoidance or very, very strongly adjusted doses. Unfortunately, there are many management guidelines that recommend avoidance of diagnostic X-rays. There are zero data to support that at all, zero. So we'll get into that at the end of the talk. We're not there yet. I wanted to say a few things about radiation sensitivity in heterozygotes because there's all kinds of mythology here as well. So radiation sensitivity in cancer and ATM heterozygotes, there's a lot of data on this because there are a lot of ATM heterozygotes and they get breast cancer. They have an excess of breast cancer. I really like this study, but I'm not sure exactly why I really like it. But this was a study where they just took all these people who had breast cancer and were treated with radiation, and they did exome sequencing of all of them, and they compared people with pathogenic variants to people with VUSs. I don't know why I like this so much, but it just feels like it's a very uniform, well-described population. And VUSs are are VUSs, and our experience with them is that 80% of them are benign, and at most 20% of them are pathogenic. I don't know that number exactly, but doing this comparison washes out differences a little. So that is a criticism of the study. But what I like about the study is it's a very uniform study. Very good comparison with that limitation. The differences may be washed out, but at least in this study, there's no difference in acute toxicity. There were no side effects that were worse than grade 3, and grade 4 is terrible, life-threatening, and grade 5 is death. But they didn't record grade 1, and there was nothing above grade 3, and there were just no differences. So that's that. And secondary malignancies for ATM, radiation doesn't cause secondary malignancies. It just doesn't cause it in these people. And for BRCA, which is Fanconi anemia heterozygotes, the risk of secondary malignancies is not increased. So this was a good study of a lot of people. Oh, this is a meta-analysis of 10 studies. No increase in ipsilateral breast cancer if you radiate a breast, like this is adjuvant radiation therapy. And this is no increased risk of any secondary malignancies among people who were radiated. So you don't get secondary malignancies, and there is no increased acute or chronic toxicity among cases versus controls. So the heterozygotes are not sensitive acutely to radiation. They don't have the killing effects or lethal effects of radiation, and like the homozygotes, they don't have an increased risk of malignancy from radiation. And this is pretty widely believed, but let me tell you, it's not what's in practice out there. Everyone knows this, but it's not the way they practice medicine. The last sort of syndrome-y thing I'm going to mention, because it's important, but it's sort of a misnomer. People talk about radiation sensitivity in autosomal dominant tumor suppressor diseases, and these are diseases like retinoblastoma, hereditary polyposis, and Gorlin syndrome. Those are not radiation sensitivity syndromes. They're not sensitive to radiation in terms of cell killing or cell mutability. But exposure to therapeutic radiation induces second hits, and it really causes cancer. So these guys really get cancer from radiation therapy. This is a picture here, crops of basal cell carcinomas in the radiation field. This was a young woman who was radiated for medulloblastoma. She had Gorlin syndrome and got all these tumors in the radiation field. And this is seen over and over again in Gorlin syndrome, and it's true of these other syndromes too. And P53, which is a hard gene to classify because it does a lot of different things. They also are susceptible to secondary malignancies following radiation, so they behave like a tumor suppressor gene disease. There are no data showing an effect of diagnostic X-rays, and I will keep harping on this because it's really important. Diagnostic X-rays are not therapeutic X-rays. So back to the patient presentation. I don't know if you guys have figured this out by now, but this 25-year-old female with T-cell ALL and developmental delay and really, really notable microcephaly, it was a homozygote for this pathogenic variant in the NBN gene. So she has Nijmegen breakage syndrome, and this mutation has a frequency of 1 in 50 in Poland. Only one in 150. Only one of her parents was Polish, so it's not like she was from a consanguineous mating. But anyway, that's where this thing comes from, that part of the world. And there are isolated populations of Slavic origin where the frequency of this is at least twice as high. So the disease is actually not so incredibly rare in certain parts of the world. It's pretty rare in the United States, though. I actually never thought I'd ever see a case of this, and there was one. So people with this have short stature and disproportionate microcephaly, so that fits this patient. They have a number of sort of minor malformations, which also fits this patient. she didn't have large ears, but she had probably had the rest of this. I didn't notice retrognathia, but a lot of times you see that in kids and they sort of outgrow it. She has immunodeficiency, B and T cell immunodeficiency. She had this T cell ALL, which is a characteristic kind of tumor you get. I talked about her intellect, which isn't so bad, and she had ovarian failure. And what about treatment? So before I met her, she was already treated for ALL. I mean, she was referred to us for ALL, but they had already treated her, and she didn't die. In fact, she got cured. And when I looked up the drugs that they use, so either through dumb luck or just because some smart person figured out what she might have, in either case, she was treated with chemotherapeutic agents, none of which caused double-strand breaks. She had no radiation, and her drugs were antimetabolites or spindle assembly inhibitors. That's like, I forgot the drug that does this, but there's a category of drugs that do this. Anyway, so that is the regimen that they use for her kind of T-cell leukemia. And like I say, fortunately, she didn't have any bad side effects. She just breezed through it and is disease-free. So what to do going forward? They talk about surveillance for leukemia and lymphoma. I know that if you catch lymphoma at an earlier stage, that the treatment is less radical, and she needs less radical treatment. So I think that makes sense. I don't know if catching leukemia at an early stage changes the course. I don't know. They talk about surveillance for breast cancer. There's not really great evidence that these people are at increased risk for breast cancer, but it probably makes sense. It kind of makes sense because they're getting estrogen replacement therapy, which probably increases their risk a little. This patient's getting IVIG. She's also getting prophylactic antivirals, and I'm not sure why, but she's probably at risk for viral diseases, but I've never seen this treatment before. So the immunology people handling her are doing that. We sent her to Dana-Farber because Nijmegen breakage syndrome is not something I've dealt with before, and I just felt like she could get an expert opinion. And they're going to follow her, like, I think once a year or something like that, which is great. But they also said add folic acid and vitamin E, and not to do a bone marrow transplant now, but it is something, like, because this patient is actually doing well, it's something to consider for her, a bone marrow transplant. And I think, like, this picture is pretty similar for what we might do for many of these syndromes, the way we might handle a lot of these things. So I think this is my last slide. So what to do? I mean, I don't know if anyone in this talk is ever going to see any of these people. I guess so. I guess like ataxia telangiectasia has a frequency in the population of something like 1 in 40,000. So yeah, we'll see it. I don't remember seeing a case before, but I know that they've gone through our clinic. I've probably seen at least one. So does it make sense to limit the use of therapeutic radiation? Yes. I mean, for the autosomal recessive conditions, absolutely. I mean, that's clearly established. To the extent that you use those things at all, you need to limit doses. For heterozygotes, there's no evidence that there's any reason to limit therapeutic radiation. And I mentioned tumor suppressor genes because therapeutic radiation, again, is relatively contraindicated. I mean, if you can avoid it, you should avoid it, but if it's life-saving, you just have to know you're going to cause secondary malignancies. Not a good thing. But this is another take-home point that I would like to hammer in. Does it make sense to limit diagnostic studies using ionizing radiation? So the existing data don't support withholding any kind of diagnostic x-rays, but a CT scan of the abdomen gives you something like 10 millirem. And if you think about these people getting imaging like every year for most of their lives, that's going to add up to a dose of radiation that really might do something. So I think multiple CT scans are probably a no-no. There are MRIs, there's ultrasound, there's other things you could use. And I believe that applies to tumor suppressor diseases as well. There aren't studies of this because, who's going to, there just aren't enough patients to do good studies, I think. But there are studies in the general population that say children exposed to multiple CT scans have a slightly increased risk of cancer. I think we should probably avoid using multiple CT scans. Withholding low-level diagnostic X-ray studies is just terrible. Like, dental X-rays give you 1,000 to 10,000 times less X-ray exposure than a CT scan, and a chest X-ray gives you 100 times less X-ray exposure than a CT scan. I think it's just criminal to tell people that they should avoid these things, and like, I think it's really malpractice, and so those distinctions need to be made. Therapeutic radiation is not diagnostic radiation, and low-level diagnostic X-ray studies are not CT scans. And that's it. So I'm going to stop sharing and answer any questions or listen to any comments people have. Yeah, go ahead.
Hi, Alan. Actually, this is an interesting case, and I think this is so rare. I think this patient also went through chromosome analysis, and then actually, I personally do like 100 chromosome analysis, and then probably they have 20%. The chromosome shows a kind of a very unique rearrangement involved the T cell receptors. Usually in chromosome 7 and 14, they have this 7-14 translocation. As a typical kind of cytogenetic phenomenon for this kind of breakage syndrome. Relate to that, actually, before, like for Fanconi anemia, we also do the chromosome breakage studies. Those are usually probably, some specialized lab. I think in Rockefeller, they used to have, a specialized cytogenetic DNA lab to do the diagnosis for Fanconi anemia and all breakage syndromes. Just from the point of like a lab diagnostic, how do you feel we should, kind of give a walkthrough for diagnosis for labs to handle this?
Yeah,
I think it's only sequencing. Yeah, okay, go ahead. Yeah.
That's a good question. So my opinion now, because diagnostic sequencing is so easy and cheap, is first step probably just ought to be looking for a genetic mutation if you suspect one of these diseases. And you're going to find it. I mean, if they have a real disease, you're going to find it. On the other hand, we saw a patient in cancer genetics some years ago. I can't remember who follows this person, but we just could not find a mutation. Now, I don't know what the diagnosis was in this person, but she was radiation. I believe she had a radiation sensitivity syndrome. We couldn't find anything wrong with her. We ended up growing her fibroblasts and sending them to those people at Dana-Farber who are experts in, Fanconi and things like that. And they said, all they said to us was, we can't figure out what's wrong with her cells in vitro, except they just don't grow. So I think that there is still a role for things like chromosome breakage studies and other in vitro studies of cells when you can't figure out what someone's diagnosis is based on sequencing.
Yeah, I kind of want to do the analysis of that patient. I think we treat initially as a constitutional study. So actually the standard analysis doesn't see anything that special, because occasionally we can see patients with some kind of a polymorphism with 7-14 translocation. Usually it's considered PHA stimulated, out of like a general cytogenetic analysis. But for that patient with that clinical indication, and then we increase the analysis to 100 cells, surprise to us, it's like really that's about 20% of cells do see those kind of T cell receptor related translocation so frequent in the percentage of the cells. So I think definitely that established the chromosome anomalies for this disease. And before used to they need to specialize the cytogenetic analysis for breakage studies, because you need to treat the cell and then to see the breakage. And also you need to, for some testings relate to SCE, cis chromosome exchange, that one you also need to add in reagents to see that kind of increase the chromosome exchange. So probably we gradually lost that part of, I'll leave that more to the specialized lab to do that kind of analysis.
Yeah, I think Arlene Auerbach was the person at Rockefeller who used to do this.
Yeah.
I haven't heard her in a long time.
I think that's a long time ago, probably some 20 years ago. I think I hope maybe they still, save that kind of, keep that kind of specialized lab to do, specialized analysis for patients.
Yeah.
I have a question. Why we don't see
notes in the chat?
Can I
Questions?
answer first and then back to the other question? So, so internal radiation, I don't know whether there's any increased risk. It's a funny thing because there are things you can't give externally, like alpha particle emitters, you can't give externally. And I don't know. I don't know the answer to that question. Sorry, neighbor. Sorry, whoever was talking before, can you go ahead now?
Yes, I have a question. We don't see the radiation sensitivity with BRCA1 or BRCA2. We only see it in ATM and Fanconi. Is that cells have in germline? Is there this like they bypass this? They have another way to repair themselves?
Wow, I'm a little confused about something you just said, because you said you don't see it in BRCA1 or 2, which are Fanconi. So what so most of these things, they use those repair systems that I was showing there. Like there's non-homologous end joining, which gets used if you don't have homologous repair. But basically, if you don't have homologous repair, your cells just don't like radiation. I mean, they die a lot. So, so there are two well-known pathways, and I wouldn't be surprised there are other pathways as well. I mean, I used to study this, and like, there are genes that sort of don't exactly fit into homologous repair or non-homologous end joining. So, I think it's still an evolving field. I'm not the expert anymore. I really used to know about this at the research level. Right now, I've kind of been out of that business for a while.
Thank you.
Any other comment or question to Dr. Bale?
Lauren says, do you know how most of these rare patients would be screened for tumors? My feeling is probably, I know for Lee-Fraumeni syndrome, which is not one of these, but it's a syndrome where you can get tumors all over the place, we do whole body MRIs every year. So I think that that's probably what we're talking about.
Any other question or comments?
Oh, the frequent fly. I see this thing. Should this patient population be advised not to be frequent flyers? I don't remember the exact dosage from airplane flights, but it's something small. It's like 10 days of background radiation. So it's like low-level diagnostic X-rays. That's what the exposure is. I used to think like cross-continental flights gave you a lot of radiation exposure. That's not true. Actually, wearing a watch that has a glowing dial, it depends on what's making it glow, but most of those are a little bit radioactive. That's a lot worse, it turns out.